when doing my research on compiling this information, I found that there was a lot of it. And I don't think that it's particularly helpful to just sort of like throw a bunch of numbers and words on a screen on a document and then expect people to be able to absorb that information. So I wanted to put the really critical information and some other eye-opening statistics in a presentation and make it visually appealing. And I also just want to warn folks before I get started here that we are going to touch on some subject matter that is really sensitive and could potentially be triggering, namely in regards to suicide. And I just don't want to like spring that on people randomly or anything like that, especially because I know I've had my own personal experiences dealing with that sort of thing. So I just wanted to warn folks about that in advance before we move ahead. So I wanted to elaborate on why the data matters specifically. Obviously, many of us here in this room and many other people in society in general have experiences dealing with mental illnesses or know somebody close to us who has. And these discussions on mental health and illness are actually becoming more and more prevalent as people continue to give a voice to these anecdotes. Having conversations about mental health can help reduce the stigma, sorry about that, associated with it, and ensures folks receive treatment sooner rather than later as well. And we'll get into that a little bit later as to why that is. We can even go a step further and reinforce our lived experiences with data and statistics. We can prove that mental health is genuinely an important topic because it concerns the public health and well-being of our society. It's not just made up of a bunch of individual stories. We have to also explore even the most seemingly taboo or controversial aspects of mental health and illness. Our society has long been affected by some of these topics that I'm going to mention in the presentation, and considering the trajectory that we're currently on, this trend will probably continue aggressively. We also want to avoid making any assumptions about the status of mental health and illness within our country, especially when we can take advantage of information that is publicly available and properly inform ourselves. And you heard me go into a bit of an update on the HFM CARES initiative. If we are going to be putting so much focus into that mental health oriented initiative, we want to be able to understand why it is that we are devoting so much of our attention to it. And it also helps us reinforce our arguments. And that's something that we always want to do, especially in the Yang Gang. Moving forward to some of the most critically important statistics that I found. These are some of the things that you will find quite easily when just doing your surface level research, namely that 1 in 5 US adults experience any form of mental illness each year. And 1 in 25 US adults experience serious mental illness, which you'll sometimes see abbreviated as SMI, each year. 1 in 6 US youth, so people under the age of 18, experienced a mental health disorder in 2016. And half of all lifetime mental illnesses begin by age 14. The number jumps to about 75% by age 24. Suicide is the leading cause of death among young people aged 10 to 34. And another very eye-opening statistic that gave me lots of hope. 76% of Americans consider mental and physical health to be of equal importance. I would imagine that we've made leaps and bounds in this realm specifically over a very short period of time. Moving forward, these are these are 2 bar graphs. The first one being 12-month prevalence of any mental illness in adults in the US in the year 2019. Overall, 19% of all adults are experiencing some form or variation of mental illness over a year-long period. With on the lower end of the spectrum being 15% of Asian adults, 16% of Black adults, and on the higher end of the spectrum, 37% of LGBTQ plus adults and 27% of mixed race adults. The other bar graph that I have here is the 12-month prevalence of common mental illnesses. So not severe mental illnesses, but just really common ones. Well, actually, no, these are some of these are severe, but there are other mental illnesses that are not listed here, which is exactly why you're not seeing the number total up to 100%. These are just the primary ones at the top of the list. Anxiety disorders and depression, as well as PTSD, dual diagnosis or comorbidity in diagnoses, as well as bipolar disorder are some of the most prevalent common mental illnesses in the United States of America as of 2019. Something really important that we need to touch on when having this conversation is just seeking mental health treatment in general. And the reason why that is because, first of all of it, the culmination of every aspect of it, therapy, medication, self-care, that helps aid and abet the recovery process for the vast majority of people. Without that, it's very difficult for people to find themselves in a better place mentally. But unfortunately, especially here in this country, and largely because this is still quite a taboo subject, seeking care in any form can seem difficult and daunting. Typically, as a result of that, finding any help in the first place is going to be one of the most prominent obstacles that an individual is going to face, even before they're able to face whatever mental health issues they are experiencing head on. The actual average delay between initial symptoms and treatment is 11 years. So people don't even find themselves in the presence of a mental health professional or any form of counseling, no matter how informal, for a really long period of time. So I have two bar graphs here. People who get treatment in a given year, typically adults with serious mental illness are going to be the ones who tend to get a little bit more treatment. But as you can see, under 50% of adults with mental illness and under 50% of youth aged 6 to 17 with mental health conditions are actually getting treatment in any given year. So there's a huge gulf that we're going to have to find some way to fill, because still the overwhelming majority of people are not getting consistent care for their mental health obstacles. And the other bar graph here is adults with mental health diagnosis who received counseling or treatment in the past year. The overwhelming majority of folks who tend to do this are going to be white or LGBTQ plus adults, but there's still only 50% of those individuals in the biggest groups getting some form of professional or informal assistance, which means that even in the highest categories, we're still experiencing a large gulf where needs are not being met. And the reason why this is important is because there are lots of consequences associated with not getting your mental health looked at, with not getting mental illnesses treated. And I have a list of the primary ones here, including incarceration, homelessness, suicide, relationships of any kind beginning to unravel, a lack of communication overall with your friends and family, difficulty relating to others, missing school and work even up into the point that you will lose your job, leading to exacerbated financial stress, even poor management of physical health, as well as substance abuse. And two of the main aspects of these effects that I'm going to be expounding upon in this presentation are incarceration, specifically mental health and mass incarceration, as well as suicide. So I want to open up with the idea behind the interpersonal theory of suicide. This theory was sort of manifested in the early 2000s, I think 2003 to be specific. And a lot of the research that's been done in the realm of suicide since then is largely based on the interpersonal theory. It's this idea that the desire to attempt or commit suicide is caused by the presence and fusion of thwarted belongingness, or the fundamental need to be accepted, and perceived burdensomeness, the belief that people have become a burden to their family and friends or society at large. All of that combined with a general hopelessness that these feelings will always exist, and they will always continue to be pervasive no matter what an individual does. And now that we have a basis of an understanding of where these feelings lie and just how intense and overwhelming they can be, we can discuss some overall trends in suicide in this country. Firstly, being that the US suicide rate increased 33% from 1999 through 2017, and as a result, it's become the 10th leading cause of death in the United States. LGBTQ plus youth specifically are 4 times more likely to attempt suicide than straight youth, and transgender people are 12 times more likely to attempt suicide than the general population. Another area of concern in the general population are men and women aged 35 to 54, where suicide is the 4th leading cause of death in the US. And if you remember, I mentioned earlier, in US youth under the age of 17, suicide is actually the leading cause of death. So this gives us an idea of which areas of the population are specifically susceptible and vulnerable to suicide. And as we are having this conversation, the suicide rate in the US is continuing to climb. And one of the biggest ways that we can begin to address this, I feel, is by learning that it's okay to talk about it. Oftentimes, I believe that people get sort of a stomach churning feeling deep in their gut when they begin to have conversations on this topic. It can be a very sensitive topic to even begin to discuss with people who you've formed relationships with for years. But if we can sort of find a way to get rid of that feeling and make it easier for people to come forward when they are experiencing, especially suicidal ideation, the idea is that people will not hide it and they will get help sooner rather than later. Moving forward to why the suicide rate is rising, we'll get into this bar graph that you see here in a moment. But first, I feel like it's really important to explain that the reasons why suicide rates rise and fall in the general population are very complex to decipher. For example, mental illness, stressful life events, a history of abuse, or adverse childhood experiences are just a few of the risk factors involved, but it's never usually, when it comes on to an individual, it's never usually one risk factor. It's usually a combination of risk factors on the individual level, which means that explaining a population level rise becomes more difficult. And also, if you will take a look at this bar graph here, or the line graph here rather, the suicide rate has climbed to similar levels in the past, which means that the exact reasoning as to why the suicide rate rises at specific points in time becomes even more difficult to find. So as you can see here, this is a line graph from 2017, the suicide rates from the years 1950 to 2017. It's deaths by suicide per 100,000 US residents in the population. So for example, in 1970, for every 100,000 US residents that were female, almost 7.5 women were committing suicide. So as you can see, we're over here on the far right-hand side, but in the past, in the 70s, in the early 90s, as well as in the 1950s, the suicide rate has climbed more than once. Moving forward to this idea behind deaths of despair. Deaths of despair specifically are deaths from suicide, drugs, and alcohol. And since 2000, these specific kinds of deaths have increased sharply, specifically for white Americans, male and female, aged 45 to 54. So much to the point where mortality rates for cancer and heart disease are actually outpaced by these increases. And a lot of research has been done in this field, but the research specifically where I got these figures from states that the general reason for why this is as job opportunities wane and traditional structures of support in society weaken, as well as effective and affordable mental health care remaining hard to find for most people in America, life begins to lose meaning, which ties us directly into that interpersonal theory of suicide that we mentioned previously. When people lose their jobs, especially blue-collar individuals that might not have a formal college education or a formal network, they begin to feel like a burden to their families, like they cannot support their families anymore. And they end up, becoming this sort of statistic, which is actually really quite unfortunate. And the other figure here is deaths of despair for white non-Hispanics aged 45 to 54. These are based on metropolitan statistical areas, which is what ACUMA is. And as you can see from the years 2000 through 2014, the units of death per 100,000 deaths of despair specifically in this country have exploded all across the country. Hold on just 1 second. Okay. So we will move on to also this figure 5 here, which I thought was particularly interesting. This is deaths of despair by country for ages 50 to 54 between the years of 1989 and 2014. For white non-Hispanic men and women in the United States, these figures have exploded, whereas in other countries like Sweden, Canada, and Australia, the figures have gone from sometimes exploding circumstances to having largely diminished over time. Moving forward, so we're going to begin to discuss the tie-in between mental health and mass incarceration. But before we do that, we sort of need to go over this concept known as deinstitutionalization in the United States, which by and large refers to the state hospitals that began to close down in the 50s and 60s all across the country. and why that all happened and how that's contributed to the current situation that we find ourselves in. Initially, the intention of a state hospital was to provide therapy, medication, medical treatment, work, and vocational training, as well as a sense of community for folks, specifically, oftentimes folks with serious mental illnesses. But in the 60s, and really this goes back to 1950 with the creation of the first antipsychotic, Thorazine, there were these three forces that culminated that sort of began to create the initial closures of state psychiatric hospitals across the country, although there are still some. Besides the creation of Thorazine and the first generation of antipsychotics in 1950, later on in the 60s, people were beginning to believe that confining people against their will was actually pretty inhumane. And some of the stories that I found while doing my research were pretty damning. A husband could call the authorities on his wife and say that she was having a nervous breakdown. Psychiatrists would be sent to their home. They would take the woman's pulse and declare her insane and carry her off. This was a regular occurrence during that time. So people began to be very, very concerned about the implications, the larger implications of that. And then also there was this desire for states to save money. They didn't want to put their money into these institutions anymore. They wanted their money to go to different things in their budget. So the first nail in the coffin, besides the creation of Thorazine in 1950, is the Community Mental Health Centers Act of 1963, wherein state institutions were dissolved in favor of quote unquote community mental health centers. When this happened, the ratio of beds per 100,000 people in any major metropolitan area dropped steadily from 339 in 1955 to only 11.7 in 2016. And the sweet spot that I found in my research is about 50 beds per 100,000 is a better ratio to attempt to obtain. Good night, Kimberly, thank you. The other idea that went along with the Community Mental Health Centers Act was that by providing SSI, which used to be referred to as Aid to the Disabled program when this was initially created, used in conjunction with food stamps and housing subsidies, would allow individuals who had once been permanently housed in these state psychiatric institutions to begin to live a life of autonomy of their own free will and volition. But this largely ended up not being the case, mainly because these subsidies and SSI payments, even the monthly maximum traditionally has always been pretty small. In the year 2020, the monthly maximum federal amounts for SSI are actually $783 a month. That's the maximum that one can hope to achieve. You're not guaranteed that, which means that you have many people who are at risk, who are dealing with mental illnesses, who are dealing with a lot of other issues as well in our society, who are living off of under $10,000 a year. They're not living a dignified life. They're not living a life that they can feel proud of. And that's actually it's a serious situation that we're going to be dealing with the fallout from for a very long time because it's gone on for so long unaddressed. The next nail in the coffin is these, well, unintentionally, I'm assuming, but I'm not entirely sure, is the signing of Medicaid on July 30th, 1965. We're coming upon the anniversary of that by Lyndon B. Johnson. This was actually at the top of his legislative agenda in 1965, and he helped to make this happen. A part of Medicaid was shifting the funding for people with serious mental illnesses from state hospitals to these community hospitals and mental health centers, and also nursing homes as well. So that funding from the government ended up going to these community hospitals and nursing homes. And a lot of these nursing homes and community hospitals also entered into shared partnerships with the federal government. So some of their funds were going towards the cost of operating these facilities. And this actually created the incentive for states to close facilities that they were funding so they didn't have to spend their state budgets on that stuff anymore. And they began moving their patients into these community hospitals and nursing homes that were funded by Medicaid. And then there was the Omnibus Budget Reconciliation Act of 1981, wherein the federal government ended direct funding for community-based nursing homes, primarily treating patients with mental health illnesses. And this is 16 years after the infrastructure that they had created within Medicaid had been signed into law. So they ended up completely restructuring everything again. Also, you saw the introduction of mandated screening of incoming nursing home patients to ensure Not that they had any mental health illnesses or problems at all, but just that they were legitimate, quote unquote, the implications of which, you know, could be quite damning. And they were obviously trying to find ways to prevent people, especially with serious mental illnesses, from being admitted into these facilities. The Omnibus Budget Reconciliation Act also mandated that states could only fund non-nursing homes for long-term care of individuals with serious mental illnesses, meaning that many elderly individuals with serious mental illnesses were castigated and no longer had any safety net in society to support themselves within, to be supported by. This also ended up segregating people who weren't necessarily elderly, but just had serious mental illnesses in general, into very large and underfunded facilities that were often for profit and reduced care and costs in the name of those profits. So just a little bit of a background on that before we got into the meat of it all, which is mass incarceration and mental health. Whoops, didn't mean to move forward yet. By and large, many legislators and policymakers and organizations that operate and advocate for change in this realm believe that incarceration has actually replaced hospitalization for thousands of individuals in the US prison system, specifically because prisons and jails hold up to 10 times more individuals with severe mental illnesses than state psychiatric hospitals do. And 70% of youth in juvenile detention have at least one mental health condition. And instead of those underlying conditions being addressed, we have youth that are sitting in juvenile detention. And some solutions, a lot of solutions they've already been proposed for decades. And that's the unfortunate thing. The first thing being restoring public psychiatric beds, moving away from the era of deinstitutionalization and providing more infrastructure and funding to states so they can create facilities that are more humane, that allow individuals who are having issues with their mental health to find the appropriate solutions for them with qualified professionals, as well as this three-pronged approach to diverting individuals with mental illnesses away from the prison system. The first aspect being crisis intervention team policing. This was actually created by the Memphis Police Department in the late 1980s. It's this idea that you take a smaller cohort of police officers and engage in intensive training on various forms of mental illnesses, as well as de-escalation techniques, used in conjunction with either a mental health court, which is focused on prescribing mental health treatment, similar to this other approach here known as assisted outpatient treatment, which is for folks with severe mental health illnesses or a history of court noncompliance being allowed to remain within the community instead of being incarcerated. Let's say an individual wasn't wanting to take their medication. A doctor would actually show up to a patient's home at a predetermined time. They would take that medication under the supervision of the doctor, and then the doctor leaves, and the person's not put in jail. They're not taken out of their environment and put into a circumstance where they might end up homeless down the line, but they're being treated with humanity and human dignity. Moving forward, to now that we have a much more deep understanding of just how pervasive these issues are, and just how much they have sort of, how do I even describe this, found themselves leaking into our society, we have to determine how we're going to move humanity forward. And I believe that there are 3 steps to this. First of all, making UBI a reality on the national policy level, improving access to mental health treatment, and viewing suicide like the public health issue it is, as opposed to a solely personal issue. And we're going to expand upon these things. First of all, in regards to universal basic income, there are 3 aspects of UBI that I believe help address a lot of the issues that I mentioned in this presentation. First of all, by putting money directly into people's hands, you are helping to reduce poverty, which will help alleviate a lot of the stress, a lot of the issues that people are dealing with that leads to them experiencing mental health issues, or puts them in situations where they might end up developing mental health issues later on in life because of the really negative circumstances that they found themselves in as a result of dealing with poverty. And also relieving institutional anxiety. A lot of individuals who have to receive any sort of assistance from the government, they know that it's a really, really tricky thing to navigate. And most people that I've ever spoken to about these things have a laundry list of very negative experiences that they've had. Even if something like this were stackable with the benefits from the government that folks were receiving, at least they would know that no matter how many hours that they work, that there's no rule, there's no weird random rule that they can break that will get this money taken away from them. They will always have this as a safety net. The second aspect is the economic buffer, namely when it comes to accessing education, indulging in your entrepreneurial desires, or taking your creative endeavors more seriously. This ties directly again into the interpersonal theory of suicide. You cannot expect human beings to continue to coexist within a reality that they believe that there is no end in sight from the suffering within. And by providing folks an economic buffer to realize their dreams, to not be trapped in negative circumstances, abusive circumstances, regardless of whether we're talking about abuse on the job or abuse in a domestic situation, this provides folks an opportunity to see the light at the end of the tunnel, to see that there is a way out, and that they don't have to be perpetually stuck in a situation, that they can have the divine ability to say, I can move forward. And also when it comes to social and emotional growth, being able to help out with your community, nonprofits, spending time with your family. A lot of people don't get to do these things, so they largely feel disconnected from their family, their friends, their community. They feel like all they do is go to work, come home and go to sleep. Providing a financial floor for folks to decide that they will be able to do more with their lives, and that they want to do more with their lives as a result, could provide a lot of meaning to people. Moving forward to improving access to mental health treatment. This is very, very important, specifically because in the current situation, 56% of Americans are seeking or desire mental health care for themselves or a loved one, specifically those coming from a lower income, military background, or younger individuals. 42% of Americans, almost half, found costs associated with mental health treatment to be too expensive, namely because of unreliable insurance coverage. But 1 in 4 Americans are regularly choosing between getting mental health treatment and paying for basic necessities, paying for their food, paying for their utilities. 38% of Americans currently have to wait 1 week or longer for access to mental health services because they are, even in cities where they are widely available, there are waiting lists. There's still not enough money devoted to developing the infrastructure to support the need that we currently have in our society for these services. And 46% of Americans actually know someone who has driven at least 1 hour round trip for treatment. Only 7% of Americans have utilized telehealth services, though 45% of those who hadn't had a chance to try it were actually interested in doing so. There's a huge gulf there, a huge gap that needs to be addressed. Some people are advocating for state hospitals to also return to a more traditional role as the hospital of last resort, functioning as an entry point for an individual with serious mental illness who would otherwise wind up in jail or prison, where they tend to be very mistreated by people by police officers and by correctional officers who don't have the training at all. They don't know how to deal with individuals with serious mental illnesses. And also creating, and some of this already exists, but more of this housing with various degrees of supervision, creating an alternative to current outpatient facilities and reimagining those facilities. What if we thought about these facilities as a way to provide refuge from a difficult world? And we offered meaningful activities to enrich and improve the lives of individuals who come to us who are struggling. If we were to reimagine outpatient facilities, inpatient facilities in this regard, the idea of asylum, the way that the ancient Greeks and Romans envisioned it, could actually come into fruition. And then there's actually another graph here on the side of social stigma within regards to accessing mental health treatment by generation. Baby boomers tend to be on the lower end of the spectrum here, whereas millennials and Gen Z tend to experience more of, well, they tend to feel more of a social stigma. Even though we make up the generations, we're talking about it, younger folks are talking about it, there is still this perceived feeling, there's still this idea, the underlying idea being that they cannot talk to their families about it, they'll end up being castigated, people will judge them harshly or use it against them. Moving forward to the final key in the puzzle here, treating suicide as a public health issue, in order to do that, you have to realize that prevention is the key. Whenever we're talking about public health issues in general, typically we're thinking about how do we prevent these issues from becoming bigger. And I found a really great study on this. It's this table here that's entitled "The Language of Mental Health Prevention Applied to Preventing Suicide and Attempted Suicide." And the categories here that you can see are intervention terminology, the approach, the target, the objectives, and the examples of possible future prevention efforts. And some of these are quite interesting, like enhancing school and community programs to reduce alcohol and substance abuse in youth and young adults, developing effective violence reduction programs among men aged 25 to 55 years, removing insurance barriers. This is a big one for access to mental health and substance abuse treatment, this very, very prevalent issue, as well as providing counseling and health services for homeless individuals and families. Also, some really cool ones here that I think I've heard people in the Yang Gang touch on. Outreach to churches is really important. So promoting church-based and community programs to contact isolated elders. I really am a big fan of this table because it addresses the issue on multiple levels. No specific group is being left out. And we're talking about things that we by and large don't see anywhere currently. So I can't help but feel encouraged when I'm looking at this table, because I think that if everyone who takes this idea seriously were to take a glance at some of the ideas that already were floating around out there, we would realize that we're actually a step closer to addressing these very serious situations than we realize. And before I wrap up here, I went through a lot of sources in this presentation, more than I think I ever have. This is actually linked, the whole presentation is linked in a Google Sheets document in the agenda, so you can actually take the chance to read the sources. I highly recommend that you do. A lot of these are very interesting. I wish that I could have made this presentation longer so I could have gone on and on about a lot of the really fascinating things that I found. I'm going to stop my screen share now, and that's the end of the presentation, y'all.